All right, good morning. Welcome to, this is our third annual Symposium on the Ethical, Legal, and Social Implications of Learning Health Systems. I'm Jody Platt. I'm faculty in the Department of Learning Health Sciences and have been honored to organize this event for the third year in a row with Kate Spector-Baghdadi and a team of really amazing people. So we'll start off with a few words of introduction. Chuck Friedman will kick off our event, and then I'll come back and say a little bit more about who we are and what we do. And Kate will give us some background on what we've done in the last few years. And then we'll get to the sort of the meat of the event with our speakers. And I'm looking forward to a great day. So Chuck, are you ready?
Well, good morning, everyone. I'm delighted to see everyone here, and I'm delighted to see myself here. Due to some unplanned and unfortunate coincidences, I was not at the previous two ELSI meetings. I have every reason to believe that what people told me about how successful they were is true, and we're all here for a third meeting, and I'm delighted to see that. I did make it for this one, thanks to the cooperation of Delta Airlines. I arrived back from China last night at 6 p.m., so I am hereby claiming I'm not responsible for anything I say. It's the jet lag talking. I want to welcome you on behalf of the university, the medical school, the other schools of the university that are represented here, and also my Department of Learning Health Sciences, of which I am very proud. I'll just say a word about the department, because I know many of you are familiar with the department, but I also know that some of you aren't. The Department of Medical Education at the medical school became the Department of Learning Health Sciences in 2014, and with that change came a greatly increased breadth of mission, and we became a department about learning. What was heretofore a department focused on education expanded its mission to include this transcendent term of learning, and we became a department concerned about learning across levels of scale: learning by individuals, learning by groups, learning by organizations, and learning at the level of very large-scale systems. And the latter two levels of scale, learning by organizations and by entire systems, invoked this concept of the learning health system, with which I became first acquainted when I was working for the U.S. Department of Health and Human Services, and which over time became a kind of holy crusade for me. And it was really a wonderful thing to be given the opportunity to expand the mission of the department, and we've done a lot of things since the department changed its name and its mission, besides just getting bigger, which we did. But much more important, we have developed some very interesting research programs and areas of academic interest. One of them, of course, is what brings us all here together: a focus on the ethical, legal, and social issues in learning health systems. We've also developed some very interesting socio-technical infrastructure for bringing knowledge to practice. We have begun a master's and PhD program in health infrastructures and learning systems, and several of our students from that program are here, and some of the first-year students in the program are actually skipping my class this morning to be here. They asked my advice, and I said I have a conflict of interest here, and will not comment. We also have a journal, which was very creatively entitled Learning Health Systems. But do we have propaganda about the journal here? Will we have propaganda about the journal? Yes, there's propaganda about the journal in your program, and this is an open source journal published by John Wiley. We're very proud of the journal, which is about to publish its first issue in volume 3. So we've been at this for a couple of years, and we would welcome your submissions, of course, to the journal. We are engaged in helping health systems become learning health systems, and we are doing this as well across many levels of scale. We're working within Michigan Medicine and the medical school in many projects. We are collaborating across the campus with the dental school and the College of Pharmacy and other entities to help realize learning health systems on our own campus. We're recognizing that the concepts of learning health systems and precision medicine and precision health are growing together as they should. And this is a very interesting development as a recognition of this convergence is starting to take hold. And finally, to conclude my remarks, I just want to make some observations about the spread of interest and effort relating to the achievement of learning health systems across the country and now increasingly around the world. There is tremendous interest in learning health systems in the UK. We're honored to have Brendan Delaney from Imperial College London here with us. In China, I was in extended conversations with Aziz Sheikh of the University of Edinburgh, where there is a movement across all of Scotland to achieve learning health systems in Scotland. Switzerland, as some of you know, has a nationally government-funded learning health system initiative. In Canada, I don't know if Kim McGrail is here yet. Hi, Kim. There is an effort beginning in British Columbia. There's considerable interest in Quebec in learning health system activities. I could go on and on. In the U.S., the state of Indiana is joining the state of Michigan in a statewide learning health system initiative, and many, many others. The point I am making, of course, is that this idea has taken hold. It is spreading, and the considerations which we will be exploring in this meeting today are vital to the continued success and expansion of the effort. So thank you very much. I'm delighted you're all here, and on with the show.
Welcome. So I mentioned at the beginning, this is a big event. There's a lot of people involved. Our planning committee has been spectacular. We meet every month or so and more leading up to the event. I'll recognize them again at the end, but if you see people who clearly know what they're doing, say thank you. Sorry, but it's true. I mean, anyway, they're here. They're all here, and there are many of them. We also have a number of excellent. This is an event that's sponsored by agents and agencies across the university, and we had more sponsors this year than we have in previous years, and I just want to thank them. Sponsors included not only our department, but the School of Dentistry, the School of Information, the School of Public Health, the IHPI, HIMSS was an external sponsor of our program this year, and I think it really speaks to the interdisciplinarity of what it is that we're doing here. Thank to them also. That's okay.
Cool.
Good.
Yeah, sorry about that.
All right. So welcome, and thank you. So one of the questions I get every year in organizing this is, what is a learning health system? So I won't spend a lot of time on that, but we will sort of ask this question again for the third year in a row. And every year, I think the answer changes a little bit. There's some fundamentals that haven't changed, but we're beginning to see it in practice, and so we're able to say a little bit more and differently about what it is. And I asked you, sort of leading up to this event, what you thought, where do you see the learning health system in practice? I'll tell you what I heard from you about what could possibly go wrong and what could possibly go right. and think a little bit about how to make learning health systems fair and just enterprises, which is part of the questions that are on your table right now. So a learning health system is in part an idea. It's also very much more than an idea, it's the people that make those ideas a reality. So it's the processes, it's the technologies, and the people and the infrastructure that make a learning health system possible. The learning health system model, many of you will have seen this before, some of you have not, but the idea is that there's a learning community that's interested in solving a problem. That problem can be solved through data, the analysis of that data, the interpretation of that data into new knowledge, and then the application of that knowledge in practice. Ideally, in a learning health system, you then learn from that experience and do it again. But this approach requires an examination of the underlying ethics behind every single step of that way. And we've talked each year a little bit about the framework that was developed a few years ago now in 2013 by Ruth Faden and colleagues, that basically rejects the assumption that there's something fundamentally different between clinical ethics and research ethics, and maybe we need to sort of reconsider the obligations of the parties involved in making organizations and health a learning activity. So let's turn now to what we heard from you about where you see a learning health system. And I think I heard back from about 20 people and got 20 different answers. But a lot of you see the learning health system here at Michigan. Some of it's in sort of a general sense, and some of it's in specific practices that are trying to understand what a learning health system is and how to put it in practice in their clinical settings. Some of you see it in my chart and the ways in which we're beginning to do better at communicating and interacting through technology with patients, in patient care. There are some systems that you've named, Kaiser, Intermountain Healthcare, that you seem to consider learning health systems. In some cases, the learning health system is in journals and conversations, and there's close relationships between learning health systems and research, precision medicine, like Chuck talked about, translational medicine. And some of you said, they just don't see a learning health system anywhere. It's nowhere. And that may be true for some of us as well. For others, it's everywhere. The problems the learning health system will solve are many, and most of them are basically leading to a health system that's better than the one we have now. It will improve quality, it'll improve efficacy, it'll lower costs, and it will help to surface problems that hopefully we can fix. At the same time, it may also cause problems that we don't currently sort of work with or try to solve. The governance is unclear. There's some concerns that we'll end up prioritizing finance over patient care. That there's many of you mentioned the resistance to change is big and no small feat. And then there are sort of policy questions related to privacy, disclosure, consent is still an open-ended question. And that we may disagree about the knowledge that comes out from what we learn from the data. So last year, one of these questions, we asked you what makes learning health systems fair and just. That question is repeated again this year, and you'll see typed up some of the responses that we saw last year. Actually, I think most of them are now typewritten there. And there's a lot that we can do to make learning health systems fair and just enterprises. We've learned a lot about community engagement over the last many decades, and we can take those lessons learned and apply them here. Trust was a big issue. Kate's going to talk a little bit about that, I think. Communication, governance, and being honest about what it is that we're doing. There are big steps and little steps. It's not an easy thing to do. Last year, somebody mentioned that we had yellow pens, and those were bad ideas, so you will see no yellow pens on the tables. We are a learning system. And talking and listening and asking questions is an easy thing to do that can go a long way. So, okay, so here comes a little bit of instruction. So on your tables, we have these nice paper tablecloths, so draw on them. Continue to add more in sort of response to the questions you see there. You also have little dots that you can sort of begin to sort of express your support or favor. Is that the word? You support, if you're basically voting, dot voting with the tiny little dots on your table. So, there'll be time for discussion. There'll be time when you're thinking about things that you just want to jot down, and I encourage you to do that. And we do listen, and we do write it. We look at what you write, so please do that. So say more. 3 years ago, Ray DeVries put up this slide as a sort of invitation. Yes, you did. This is your picture. As an invitation to start the conversation. And last year we invited you to keep the conversation going. Somebody asked us what happens after the parachute lands, and I'd say we're sort of here. So let's see where we've landed and have a good session here. So Kate's now going to sort of give us a little bit of review of what we've learned so far and where we're headed next. Thank you.
Hi, everyone. So one of our goals for this symposium was not to have just sort of this iterative once a year moment where we all come together and we say something and then we forget about it. And next year we come together and maybe we say some new things and maybe we forget about the old things or maybe we repeat them, but to actually start to build a community where we remember the past things our colleagues have said and we build upon them so we can actually move the ball forward. And we were talking about this a little bit yesterday in our workshopping, how the goal of this symposium is more than just, again, presentations and articles and grants, but to also start to bring people together from around the institution, from around the country, and even from around the world to start to build this ELSI-LHS community. So one of the things that we do towards that goal is we do a quick review of the things that we've learned in the past. So, some of my speakers can desperately be like, oh, like they said last year, so we can work it in. So I'm gonna start with 2016. And this was our first year that we did this. And so I went through and I sort of tried to pull out a couple of the main themes of the things people were talking about. Our first theme of 2016 was this sort of tension between research and clinical care. And we had John Lantos come and speak with us about this idea that there was this presumption that the clinician was, of course, always acting in the patient's best interest, but that the researcher was potentially evil and had this sort of conflict of interest. And in particular, when a clinician went from a clinician to a clinician researcher, that somehow that was a transformation that should be protected against. And I thought that that was obviously a very interesting observation. And he also talked to us about sort of the risks of standard of care research, which is also a theme we're going to come back to today. Our second talk was Dr. David Magnus, who's also with us again today, and he was particularly talking that time about sort of the comparison of attitudes of patients and IRB professionals on research with medical practice. And that's a theme that we're going to revisit again today because it's a really important one. How do we actually implement this learning health system? And this last theme, and the last person on this theme was Dr. Todd Rice from Vandy, who was talking about the example of his ICU as a learning health system and how they give patients notice and consent. And this was so interesting that we actually decided to devote our first entire panel to this today, talking about ELSI-LHS in practice, which is something that we haven't been able to do a lot because not enough people are practicing it, but fortunately, I think we're at that point. A second theme is the importance of community engagement. And we had Ken Key and Yvonne Lewis from the Healthy Flint Research Coordinating Center join us to talk about that. And they sort of explain the difference, sort of the continuum of community engagement, and the difference between research that's academically driven and oriented and put forward, but community placed, and research that's actually community partnered and starts with a conversation with the community as opposed to, oh, did anybody call the community representative and tell them where to come to this meeting at the end? And then the third theme, which is a theme that we have very much tried to focus on each year, was not building bias into these systems as we go from them from the ground up. So Dr. Patricia Kingori from Oxford came to talk with us, and she actually gave this really fascinating conversation about sort of the sociology of architecture, and how to build and how to conceptualize that when we're building data systems. And she talked to us about building bridges, for example, that were too low for buses to get under on the way to the nice beaches, or building lovely parks in inner cities and then putting gates around them and requiring keys for access, or building park benches that have breaks in them, presumably to keep people from sleeping on the bench, but might also keep people who were larger than the spaces that will get left from resting while they're outside exercising. And so perhaps they don't use that space to exercise because they can't sit down and take a break after they've done so. And then Vince Bonham from NHGRI also came, and he talked to us a little bit more about sort of race in the learning health system. He gave us some examples, and this is a theme that we're also going to come back to again today with Shaniqua Collier, so I'm not going to delve too deeply into it, but that will be something that we will revisit. So then in 2017, we focused on, one of the themes was the tension between public and private databank systems. We had John Wilbanks from Sage Bionetworks come and talk to us about how much money is being invested in private industry and making informed consent fun and accessible. So people want to pull out their iPhones and they want to join your research project. And imagine writing into your NIH grant, we need 20% for R&D for recruitment. It's simply not going to happen. And what a major hurdle that is for academic researchers when we're competing with private industry to get participants. And we had Lizzie Pike, who's a director of privacy policy at HHS, also come and talk to us about the diverse ways that these 600 million samples are ending up in our databanks and where they're going. A second theme was sort of evaluating bio and data banks as a common good and the implications of seeing these banks as a utility as opposed to a private ownership issue. And we had Ken Goldman from the University of Miami, and he very forcefully and colorfully made the argument that privacy is not an absolute right and it must be balanced against others. For example, the right to participate and the right to benefit from science, as well as talking about sort of informational free riders, sort of this public health concept of, people who don't vaccinate but plan to rely on others vaccinating and herd immunity. And he was applying that to data. And we don't want to contribute our own data because we don't want to take a privacy risk for ourselves, but we want to benefit from other people's data. And the third theme, again, was how do we build these systems with equity? So we had Jun Ho Yu from the University of Washington, who talked to us about the difference of equality, equity, and then liberation, and what that means when we actually take down those fences for both better and worse in some circumstances. We had Dr. Deborah Matthews from Hopkins University talk to us about reciprocity. Who's contributing to these data systems? Who is sacrificing? And then who is ultimately going to benefit? And then we had our own Dr. Melissa Creary from the University of Michigan introduce us to the concept of bonded justice and this attempt to distribute health rights without disturbing or exacerbating initial inequalities. And last, there's also been a lot of really good empirical work that's also happened. There's lots of it going on in the University of Michigan. There's lots of it's going on nationally and internationally, but just a couple highlights. This expectation that people will actually actively opt into this kind of research. And even when it's de-identified, that might make people uncomfortable. And that's from Dr. Reshma Jaxi, who's the director of our Center for Bioethics, as well as this concept of non-welfare interests from our own Dr. Raymond DeVries, and this idea that the majority of people actually say, sure, use my data, my specimen for whatever you want. But when we actually break it down and we're like, well, what about for weapons of mass destruction research? Or what about for abortion research? We actually lose the majority of them and what that means. And then as Jody mentioned, we've also done a lot of work on the concept of trust and the importance of trust to the learning health system and when that trust is warranted or not. So that takes us to 2018, and we're very excited about our panels today. As I mentioned, our first panel is actually going to be our first full panel devoted to people actually operating within learning health systems. And then again, we're going to come back to our important theme of equity and ethics. And then last, we're actually going to have an entire panel devoted to empirical studies in ELSI-LHS and what further research we need to do. So with that, I'm going to invite our first panel to the podium.
So welcome to our first panel of today, Reports from the Field. As you heard from Kate, many of the speakers in past years have focused on the theory underscoring a learning health system. But today, we're fortunate enough to have three speakers who are going to talk to us about their own experiences actually operating within such a system and the promises and challenges we should be prepared for in the future. Our first speaker, Professor Brendan Delaney, is Faculty of Medicine in the Department of Surgery and Cancer and Chair in Medical Informatics and decision-making at Imperial College in London. He is a general practitioner and has academic background in clinical research informatics, clinical trials, health technology assessment and modeling, and patient safety. He is associate editor of the Journal of Learning Health Systems, a member of the UK Health Informatics Research Network College of Experts, and the FAR Institute's primary care lead. His main research focus is the learning health system, using informatic tools to link both knowledge generation and knowledge utilization to route healthcare IT systems. Welcome, Professor Delaney. You can stay there for a second. I'm gonna read. You want me to read through all of them, right? Okay. Our second speaker is Dr. Ramesh Nalia, who is a clinical associate professor and director of predoctoral clinical education at the University of Michigan School of Dentistry. He focuses on process evaluation with an expertise in healthcare, education, and healthcare economics. His research studies were the first to use nationwide data to highlight emergency room resource utilization for managing dental conditions in the United States and is internationally. Sure. No, you're all good. I kind of lost. He's a pioneer in the field of hospital dataset research for dental conditions. Dr. Nalia's professional mission is to improve healthcare delivery systems through improving processes, minimizing inefficiencies, reducing healthcare bottlenecks, and increasing quality and task sharing to achieve a patient-centered and cohort healthcare system. Thank you for joining us. Our final speaker is Dr. Michelle Meyer, who is an assistant professor and associate director of research ethics at the Center for Translational Bioethics and Healthcare Policy of Geisinger Health System. She's also faculty co-director of the new Applied Behavioral Insight Team, AKA the Nudge Unit. Previously, Dr. Meyer was an assistant professor and director of bioethics policy at Mount Sinai School of Medicine Bioethics Program and adjunct faculty at Albany Law School. Prior to that, she was an academic fellow at the Petrie-Flom Center for Healthcare Policy, Biotechnology, and Bioethics at Harvard Law School, a Greenwald Fellow in Bioethics and Health Policy at the Johns Hopkins and Georgetown Universities, and a research fellow at the John F. Kennedy School of Government at Harvard. She earned a PhD in Religious Studies from the University of Virginia and a JD from the Harvard Law School. Welcome. Our final colleague on the panel today, joining us for the discussion component, is Dr. Joyce Lee, who's a physician, designer, and researcher, and the Robert P. Kelch Professor of Pediatrics at the University of Michigan. Her work focuses on the development of learning health systems using the methods of clinical informatics, quality improvement, and patient-centered participatory design, studies of collaborative innovation networks, and patient-centered innovation, and integration of the maker movement into healthcare. Thank you for joining us. So each speaker will have 15 minutes to present, and I'll be keeping time down there. And we ask the audience to hold your questions until the end, when we'll have about 30 minutes for discussion. Dr. Delaney, the floor is yours.
Good. Thank you very much. And thank you very much for the invite. Very early in the snow for me, I have to say. But, I'm a general practitioner, which is, I suppose, from the US perspective, something between a general internist and a family physician. And the problem that we have is we are the gatekeepers to the NHS, the gatekeepers to care. Patients come to see us for onward referral if necessary. And I used to say that our job is a bit like looking for needles in a haystack, because we need to pick out the patients who have potentially serious conditions like cancer from most of the patients who don't have very similar symptoms. But I think actually it's more like looking for a very specific needle in amongst a bunch of needles in a haystack. You've seen this learning cycle. I'm not going to explain that again, but I'm going to use it later on. This is what it looks like in terms of an infrastructure. So if I twist that round, I can stand over here. What we have, and I've colored it in the same colors, and I'll start here. We have an electronic health record system, which is being used to support clinical diagnosis, and coding of data using a plugin. The activity of that plugin creates new records in the EHR, which are then extracted, linked with other health data sources, so data from hospitals, cancer registries, and patient-reported outcomes, to create a linked episode of care model, which is then anonymized, passed on to analytics using a NIME tool, Bayesian nets, which creates new facts which are put together to create knowledge in a digital framework which drives the data connector to the EHR and the plugin for the combined decision support and coding support. So that's what an infrastructure looks like, and that was developed over the period from 2010 to 2015. The key piece underpinning that, the knowledge repository, is an ontology with a general model of diagnosis linking reason for encounter, differential diagnoses, cues, symptom signs, etc., to which there may be codes bound, so you can choose your terminology and you can choose batches of different codes, and shortcuts like history of IBS for history of irritable bowel syndrome to make it easy to operate. And that runs centrally using a stack of services, essentially RESTful web services, and a client which is currently written in C#, which sits alongside the electronic health record. So what it looks like is here's a electronic health record. It's one of the 3 primary care records. For our simulation evaluation, which I'll describe in a minute, they put a little button up there for us to trigger it. It asks, first of all, what's the reason for encounter? Why is the patient here? We supported chest pain, abdominal pain, and shortness of breath for our evaluation study. And once that's been entered, the GP gets a list of differential diagnoses ordered and specific to that patient. So age, sex, comorbidity, underlying risk factors that are known, and that's produced from the ontology. And they're asked to simply read that list. This is our primary intervention to improve diagnosis. It's opening people up at the very beginning of hypothesis generation to other possibilities than what they may already be thinking about. There's a whole load of research behind this, from theoretical things in other fields to work that we've done, basically saying that if you try and change people's minds later on, they reject it. If you try and influence them early on, they include it into their decision-making process. It's working on our subconscious decision-making. Once that has been read, drops off to the right-hand side. There are 2 data entry fields. This one, which is an ontology-driven predictive text tool, and this one, which is a shortcut, which lists all the cues available for that diagnosis. And as the cues accumulate here, this list reorders. Right, so it's a dynamic tool. When it's finished, it works through the API into the EHR, and this codes are saved into the health record along with any associated text and in the right structure for that health record, so it's available for extraction. We've done a high-fidelity simulation with this. So we had 34 GPs who were already users of the particular health record system we built it with, 12 standardized patients who were actors, who were trained in a role in medical education, undergraduate and postgraduate, to be patients and to actually score how students and doctors had done in terms of their communication. And there was a range of difficulty for the cases, and the cases were built carefully so that there was enough information to actually make a diagnosis. Now, it's worth pointing out that to me as a GP, a diagnosis means what I think the patient has wrong with them when I've finished talking to them in my consultation. It's not the pathological or radiological diagnosis, the final diagnosis for a patient who's in specialist care. Now, that's a really important definition. What did we find? First of all, we found the diagnostic accuracy increased significantly with an odds ratio of 1.4. It's an absolute increase of 8% in accuracy. And if you take a broader measure and we ask people, what's your differential diagnosis or your measure of uncertainty, we found a similar measure there. Appropriateness of management improved. This was based on some criteria. Management shouldn't cause harm to the patient. There was a diagnostic certainty score on a visual analog, and the number of symptoms or signs that were coded in the record, not just written, went up from 1.6 on average per consultation to 12.35. It's a massive increase in the amount of coded information contemporaneous on symptoms and signs, which are the drivers of the availability of data. And not only was this a big increase, we've had a master's student doing some work on this, but practically all, 9 out of 10 of the things that were coded in the EHR alone were things that were in association with or in favour of the diagnosis that the GP thought it was at the end of it. Everything else was ignored. And even when you looked at text and what people had written and the concepts they'd written, there's still a strong bias in favour of that diagnosis. So you're really missing the broad level of information that you need to define good diagnostic rules. So that's where we are. We now have funding from Cancer Research UK to move the system towards cancer as an exemplar. So we're working on 5 cancers with 50 reasons for encounter, covering a wide range of presenting problems for primary care. We're expanding out our ontology to cover those. We're reworking some of the technology to update it a little bit, Smart on Fire for those people that are aware of these things. And we're about to go out early next year into 40 practices to do a feasibility study to see whether we can get them to use the system enough to then roll it out into 1,000 practices to really start to get the power, because you need, if you want to say pin down good prediction for something like myeloma, you need about 3 million episodes of care. So you need a lot of data. So thinking about the capture of information, the performance to data, and I tend to like the word practice, actually. I think clinicians find the idea of judging performance slightly threatening, at least I have when I've presented this. So I'm going to call it practice to data. And the key to this is not just more data, it's carefully structured data following Larry Weed's episode of care model. Reason for encounter, symptoms and signs, diagnosis evolving as an episode of care label over time. So an episode of care is someone who comes into healthcare and eventually may or may not have a diagnosis that's very precise and pathological, but almost certainly won't, but has an evolving diagnosis. And you need to link those together. So thinking about what you need to do from an ELSI type thing, well, clearly you need to get this information into the electronic health record. So the health record vendor is responsible for maintaining the integrity of that record, for having the right kind of codes in the right place in the record, and needs to sign that off and certify it as safe for use. And if you're sitting there with a patient and you've got this system running, how do you consent that individual to have that information put in to be used in learning for diagnosis? If you make them go through a formal consent procedure like a clinical research, the thing will fall flat on its face, full stop. It's not going to work. If you put in a thing that says, by operating this system, the patient is consenting to have their data and make it sort of one click, I still think it's going to defeat the object. This whole thing is designed to be part of the clinical workflow, to seamlessly integrate the decision support with the knowledge collection. So we have a system where we're included in the GDPR processing notice that's up in the practice. So what happens to practice data? GDPR is a European directive that came into force this year, which the UK has adopted, which basically says you can opt out, but otherwise your data will be used. And it's part of establishing trust. The data linkage aspect, this is from NHS Digital, and I think Chuck would agree that's probably a learning system, and it's straight off their website. So we're using NHS Digital to link up with all the cancer episode things, the cancer registries, the outcomes, the pathology, the hospital episode statistics, so that everything that happens across the healthcare system with the primary care data. We're not doing anything bespoke, we're just using those routine systems. We're identifying the patients who've had the record because we're putting a coded stamp in that we can pull them out. We know which patients the system has operated on. So moving on to think about how we take that data and put it into knowledge, there's a lot of interest currently about AI, and this is really an AI system to some extent, and how that can be certified. Is knowledge what you have to say is the legal responsibility, or is this knowledge now a software artifact? So how do you governance that? What are the legal requirements for regulatory authorities to say you can use this in clinical care? What standards can be used to support these validation cycles, and who owns this knowledge? These are really very, very important questions, particularly around intellectual property. Now, we're going to allow College of General Practitioners to own this knowledge on behalf of the profession in the UK, because I want somewhere safe, that's going to keep it in trust, that's a public body, and will keep it as a public good. I'm not going to make this a proprietary system. There's plenty of that going on. So this is the Cancer Registry and Analysis Service. It's the linkage of the data. It looks quite complicated. This is the ovarian cancer pathway data, but actually, with a bit of machine learning on this, a bit of computation, it's actually quite understandable what's going on here. These are patients having different treatments and investigations. So there's a very rich data available from the NHS. There's a standard for medical device software and validation. I won't read that out for you, but you can see there's a very clear pathway from development and planning requirements. This is the kind of thing that software engineers who work to develop software are very used to doing. And we need to consider knowledge actually as software in this context. There are also important standards around information security and management. Where do you keep your data? And a developing standard on ISO 8001, which is about complex health IT environments and how they should be implemented. And this is actually in ballot and ongoing at the moment. There's also work from the British Standards Institute and ANSI, which is due to report in early 2019. I'll come on to that briefly in a minute. So we've now got round to putting knowledge into practice. So who has the legal liability for decisions supported by the DSS? Well, this isn't a recommendation system. This isn't something that a patient is using. It says, call an ambulance, go to the A&E, don't worry, do this. That I think is even more problematic. This is something which is involved in the shared decision-making in the clinician's brain. It's influencing the clinician. However, it's a complete cop-out to say it's the clinician's responsibility. It's a shared responsibility, therefore there is a liability to the system, and it does have to be regulated as a medical device. Should that be applied to the knowledge or to the interface? What about the ethics and the trust of patients going to a clinician who are now in a kind of extended practitioner role with the learning health system behind them? Look at the interactions across the interface. These are the workflow between the evidence service, the health record system. That again has to be certified it's doing the right things and not making mistakes. There is an ISO standard with risk for medical devices, incorporating the principles of safety by design. I think this is highly applicable to learning health systems. And there's a list of things there which need to be done. Putting protection into the device itself, i.e. the software, providing the information that's necessary. And there is a legal framework for this, looking at risk-based approval. And I think the risk-based approval is really critical. And the question for the learning health system is, when do you have enough data to say you move from collecting data, which is what we're going to be overtly doing for our first couple of years, to saying we're now providing you with decision support? At what point do you start the cycle? Because that's critical, and I think it's something you have to work with regulatory authorities. We've talked about fairness. So, in summary, I think we need to think about these issues, defining what a cycle consists of and how it should be versioned. What are the important outcomes that the system is setting out to achieve, and what would a validation of that system be? What are the ways of controlling bias across cycles? And what would be the risk-based approach to conditional licensing? This would all have to be documented. How do you find the start point? And what's a life cycle change? What is a cycle? And how do you know that it's a cycle? How do you track it? How do you place in the system a tag to say this was the certification of this cycle at that point in time that influenced that patient's care? Track the provenance. And how is it supposed to inform human judgment? You can't just put it up there as a black box and say clinicians will use it. How do you know, and can you show that it is going to genuinely influence them in a positive way? These are all, in this knot of evaluation, validation, and the legal and ethical requirements. I'm going to skip that slide and just say that this is very much a team with my colleagues back in the UK, the EHR vendors, and also our funders since 2010 and ongoing. Thank you very much.
Good morning. What a delight for me to speak after a colleague from the Commonwealth. And what a horror for you all. So I'm from the School of Dentistry. My name is Ramesh, and I'm here to speak about our experience at the School of Dentistry. This is the task force that was originally charged with implementing learning health systems at our school. We've now grown with a couple of other people. But I want to tell you a little bit about the School of Dentistry, which you may not know. University of Michigan School of Dentistry has been ranked the #1 dental school in the United States for several years. And in the last couple of years, it's actually #1 in the world. So it's a really terrific school. Send your children there. But also, our dean, who's here today, Dean Laurie McCauley, earlier this year started thinking, what is that thing that we can do to really stamp University of Michigan on the profession, not just in education, but in the dental profession? And what is that thing that we can do to serve as a role model and lift up the whole profession? And so many ideas were talked about, and it was concluded that learning health systems would be that thing that we would use to accomplish these goals. But we didn't know much about learning health systems. In fact, this is a graph of knowledge of learning health systems. So I'm just joking, of course. But you can see that our knowledge is very low. We have some relevant skills, our task force, in that for the last decade, the research that I've been interested in is hospital outcomes using big data. And then we have 2 excellent data analysts in our group. We have clinicians. We have a PhD in pain research, a PhD in educational assessment modalities. So some relevant skills and a lot of passion. But the thing that we had to do is we had to learn more about learning health system because it is a somewhat complex concept when you're starting out. So this started off with a lot of conversations with Dr. Friedman, with Alan Flynn, diving into the literature. And then there's another barrier that we faced, and that is that a lot of the fundamentals that you need to implement learning health systems, those frameworks are actually not there in dentistry. So let me tell you about those things. Measuring outcomes. We actually don't measure outcomes very well. Our profession is largely fee for service, and we can tell you all the stuff we've done. Now, I should say that schools of dentistry are different. Academic institutions, which only represent about 2% of the care delivery, very small. We have quality assurance committees, and we're looking at quality all the time, and we have to report those numbers and all that sort of thing. But if you go to an average dentist down the street and say, what is your success rate with root canal? First thing they'll say is, how do you define success? Because we actually don't have an agreement on how we define success in a root canal, right? And the next thing is we don't really measure that number well for me to tell you it is this number, right? We don't measure it, I should say, in our institutions. Our profession is an interesting one. It is 65% of the care delivery is in solo practice. So that's the predominant model, solo, single dentist practice with really no affiliation. And this is sometimes a big draw for people who choose dentistry is the autonomy. But what does that mean for quality and for measuring and for patient care? I don't know. I'm not saying anything good or bad. So the next thing, data pooling. We also don't do that well. As I've just described the framework, we don't pool that data very well. Again, schools of dentistry are ahead because our volume of providers is higher and we have more data, but it's not big data, it's medium data, right? And then we have some initiatives to pool data from academic institutions, but still, as far as I know, the expert actually, Lynn Johnson, is here, and I know we're working to improve that, but as far as I know, we have 8 institutions. So 8 out of the 67, that's sort of 0.2% of the care delivery in the United States. So it's not a good framework for us to implement learning health systems. Again, variability. There's enormous variability. This is why every few years there's an expose that says, I went to 5 dentists and they had 5 different treatment plans. I'm going to tell you a secret. All dentists are good people. Okay, that's true. But there's a lot of variability. So I trust Dr. Macaulay. I would be her patient, same with Dr. Cornwell. But if the 3 of us looked at x-rays, we would probably have slightly different opinions. And that's because there isn't great, that's the next 2 points. There's not strict standards of care or guidelines in our profession. I know that there's research that people who value autonomy go into healthcare, but I think that's exponentially true of dentists. I'm going to tell you about 3 studies real quick. First study, the number 1 reason that people choose dentistry as a career is autonomy. Next study, the number 1 reason that people leave a dental practice, lack of autonomy, right? And there was, the third one is the practice setting that dentists like to work most in, the one that affords the most autonomy, right? So autonomy does not have to be in conflict with standards of care and guidelines, but sometimes in the discussions in our profession, it may be. So like I said, there's a lot of barriers. We didn't have a lot of knowledge, and so what we thought is to really do this well, we have to start small. We have to have early wins, and we have to use those wins as a platform to educate our faculty and dentists about what learning health systems is. So we split our goals into 3 ideas: an administrative project, which we thought would be easy, an educational project, and a clinical project. So the clinical project right now is just an idea. The educational project, it's very early implementation, but I'm going to talk to you about the administrative project. 206,851. This is the number of patient encounters we have each year. So you can see it's kind of a medium-sized hospital. And when you break it down by division, it's about 60,000 in our dentistry program, that's pre-doctoral education, about 125,000 in our graduate programs, which is like orthodontics, endodontics, that stuff, and about 23,000 in our faculty practice, which is an independent private practice where the faculty see patients. Now, this is our revenues. Now, before you all quit your jobs and come running to the dental school, I want to tell you that dental education is actually very, very expensive. In order to supervise students who are seeing patients, the faculty to student ratio is 1 to 6. So our margins are very, very tight. So I haven't put our expenses here. This is just the revenues because I want to talk a little bit about revenues. 45,000. This is the number of failed or cancelled appointments each year. So this is 20% of our appointments. And this is the issue that we wanted to tackle, okay? It's a $4.5 million problem. And in the context of a tight budget, that's important. But we actually chose to focus on these 12,000, which is, so there's actually many different types of cancellations. There's cancellations because the provider was sick. Can't blame the patient for that. There's cancellations, believe it or not, there's cancellations because the patient couldn't find a parking spot. So there's various other cancellations. We wanted to focus on failed and cancelled within 48 hours. Because with those appointments, it's difficult for us to bring in another patient, and it's an issue of access to care. We're a significant public health care deliverer, and we're a state school, and so that's an important issue for us to think about tackling. And that's a $1.2 million problem. And just to let you know, if we were able to turn this around by 5%, that's significant money. So, just wanting to move the dial a little bit is a great early goal. So like I said, we have 2 terrific data analysts, and we started pulling data. And so the blue here, in fact, in all of my slides now, the blue is fulfilled appointments. So this is patients who actually came, and the red is failed appointments. And the yellow is, the others are different types of cancellation. So you can see that we have 3 peaks. This is by age, sorry, I didn't say that. This is by age. So you can see that we have 3 peaks, which was interesting to me. One is around 15, 16. We have a peak, that's the first peak. Then we have another around 30. That's really fascinating to me because we have a lot of problem with college students because Affordable Care Act help a little bit because students remain on their parents' insurance, but that's only helpful if the parent's medical insurance includes dental, which is not common, right? So people often go missing once they're out of the school system, and they come back when they're 30 at that second peak. They've got a good job, you know, life is a bit more stable, they have insurance, and now they need their teeth fixed. And then the next big spike is the 65 to 70 age group. Okay, that's just informational. So now I'd like you to take a look at these two columns. The one on the right is very small, but you can barely see any red. In fact, there's very small red. The column on the right is patients who confirmed. The column on the left is patients who did not confirm. So the attendance rate is much more when they confirm. It's actually 88% versus 78%, right? But it turns out that we make it rather difficult for our patients to confirm. So we have an automated voice call system, right? So we have about 13 clinics, and 2 of them use text messaging, and the rest of them use automated voice call. And if you're like me, thank you. If you're like me, you sorry, that time just threw me off. So if you're like me, you don't answer those voice calls, right? And so then when it goes into voicemail, you're not able to press 1 to confirm, okay? So we wanted to make it easier to text message. The thing that I want to mention is the ethical and consent issues that we face in terms of getting consent, because we actually gain consent in 3 ways. So we ask patients, what's your primary way to contact you? And if they say mobile, someone might say, well, then it's okay to text them. But we actually have another layer saying, so then can we text you? And so then we have another layer because their first text is another consent. And so this, we've had discussions about this, perhaps necessary, but this has been a roadblock for us to move this because we don't have a large proportion of our patients who have okayed all 3 consents. They get lost on the way. I'll tell you this real brief. This is number of days after you called for an appointment. When was the appointment after you called, right? So you can see right at the very start, the first column is very high. So if you call today and your appointment is tomorrow, attendance is very high. But you can see that it gradually falls away as it goes away from the day of the call, except with one exception. Do you notice there's a spike every few days? We had no idea about this. It's so fascinating to us. We call it the 7-day spike. And it just turns out that on every 7th day, there is a spike. So this could be patient factors or student or provider factors. So so for me, I have other responsibilities at the school, so I see patients on Friday. So all patients that want to see me, they book their appointments every Friday. And if they want to come on a Thursday, well, that's not my patient. I just can't see that patient, right? And the other thing is patients may have a day off on a certain day, and so they're scheduling every 7 days. So we have this 7-day spike, but apart from that, it's generally getting worse. So what we're trying to do is, one thing is we actually, don't make it easy for our students to take advantage of the 7-day spike. We also didn't know that existed. But students to make an appointment, unlike me, where I can just see my schedule and book it, students first have to request a chair. It's quite a complex network. They have to request a chair. Then they have to request that the administrator puts the patient booking into that chair. It can take 24 hours. So they can't say to the patient, hey, I'm going to see you in 7 days. Can't do that. They can make a tentative appointment. So we're trying to change this by assigning students to sessions. Another thing, I'm running out of time, so I'm going to skip this because I think there's something more fun to talk about. So this is attendance by zip, okay? And I think we have chosen not to do anything about this, but I just want to tell you about this because I think what I learned is that we all know that data is powerful, but data can also be dangerous, I think, because you can see here the blues are zips where attendance is a little bit better than average, and the darker blue is the better and better it is. And the orange is a little bit worse than average, and the worse and worse it is. Now, what we could do is look at people's zip and put a limit on the number of people we take from those poorer attending zips. That would increase my attendance and my revenues, but it's not the right thing to do. And I can tell you, I'm not even going to put that data up, but I can tell you the same thing for race, ethnicity, and insurance status. And you may be all horrified, but truthfully, we do this in the dental profession. because we limit the number of Medicaid patients that we see, and only about 1/3 of dentists accept Medicaid patients. It's a whole other conversation that Medicaid reimbursement is very low. It is about, in this state, 20% of commercial insurance reimbursement. So that's another conversation too. But I'm just saying that this seems horrific, but we actually already do this. So a way that we thought, so this kind of grouping is bad, right, and perhaps unethical. So what we thought is, can we group in a positive way? So what we're planning to do now is to group patients by risk and send them customized messages. Once we get the text message system up and running, then we don't just have to send text reminders. We can send a text to a YouTube video, which is, oral health education for a high-risk patient, or someone with periodontal disease, or someone who has newly received complete dentures. We are limited just by our ideas. So these are some of the actions that we're doing, and with that I'll end it. Thank you. I think the arrow, if you use the arrow.
Okay, good enough. Hello. So I'm going to talk, we've heard a lot about data analysis, and we generally, when we talk about learning health systems, talk a lot about data analysis. It's very important. It's something that I do a lot of myself, especially at the intersection of precision medicine. But today I'm going to talk about the other, what I view as the other critical tool in the learning health system toolkit, which is pragmatic trials. In particular, I'm going to be talking about stakeholders' perceptions of pragmatic trials, because I think that stakeholder perceptions is one potential obstacle to implementing a learning health system. So first, let me acknowledge what should be obvious, that although pragmatic trials, sometimes called field experiments or A/B tests, can critically improve human welfare, they certainly can raise ethical issues. Some of them raise enough ethical issues that it would be unethical to even offer such a trial. So for example, we are not in equipoise as to whether parachutes or lack thereof is comparatively effective in jumping out of an airplane, right? We might be in equipoise over choice A or choice B, and so it would be ethical to offer entry into an RCT or a randomized evaluation of those two interventions, but people might have preference-sensitive decisions, right? So women might plausibly prefer mastectomy, a radical mastectomy to lumpectomy and radiation, or vice versa, and so we would, of course, want to get individual consent for those. Finally, there are sometimes equality issues. This is my favorite case. This is actually a real thing. This is a real trial that happened where people were in equipoise about two different facelift procedures, two different stitches or something. They're stitched with this loop or that loop. It's not a sensitive preference decision. However, this was operationalized on the same face. And you can see scientifically why that would be extremely valuable. It allows you to compare two sides of the face, but you can also imagine that if you don't have a null effect, right, if A or B is preferable, then you have individuals wandering around with two different sides of their faces forever. So, okay, there are three different broad sets of ethical concerns. What I'm interested in, though, are A/B tests, if you will, for short, that don't raise equipoise issues. They aren't preference-sensitive decisions, and we don't have equality issues. So in other words, at least temporary inequality or differential treatment is acceptable in the pursuit of learning. And to crystallize this, let me give you a recent example, not from healthcare. Okay, so Pearson is this large educational software company. They create software, they send it out to colleges and universities, including for computer science problem sets. So recently they conducted an RCT, and in one condition, people were and I would say this is a cluster randomization. So this is the equity issue, right? No one is being compared on a curve within the same class or even within the same university. These were randomized at the level of the university to either get this anchoring condition. The hypothesis was, if you say, look, most people take 26 times to get this right, don't give up. Or to get a mindset intervention where it says, like, look, it's just not, being naturally born a programmer isn't a thing. You actually have to practice, right? So another form of encouragement. or no encouragement, which was the status quo. Now, I can't prove this, but my suspicion, I mean, as far as I know, no one objected to what had been until this RCT, the status quo. So everybody got the C condition. Everybody got no encouragement. They just got these problem sets. You either tried them or you didn't. I can't prove this, but my suspicion is that if the CEO of Pearson had said, this is a brilliant idea, I am positive, my intuition tells me that encouraging students is going to work, because why wouldn't it work? It sounds totally intuitive. I'm going to give that to everybody here on out. My suspicion is nobody would have cared. But that's not what they did. They, in my view, admirably wanted to see whether their intuitions were correct, and so they ran this RCT. It's a good thing that they did, because the results were mixed. In particular, the results suggested that people who were encouraged in either the A or B condition actually attempted fewer problems than those with no encouragement. Alas, public reaction was not relatively supportive. So we wanted, however, and we can all think of examples from healthcare, the support study, for those of our who knows it, on the resident duty trial, arguably raised similar issues, but those are very complicated, and I'm not going to go into those. But we wanted to figure out whether we could systematically observe something like a pattern of reactions where we, people, find it less appropriate to conduct an A/B test than to implement an untested policy, either A or B, for everybody. And if so, why is that happening? And are there ways that we can communicate learning health system activities, in particular pragmatic randomized evaluations, in such a way that stakeholders don't espouse this A/B effect, what we occasionally call the A/B illusion? So we conducted 15 online between subjects vignette experiments. Don't worry, I'm not going to explain all 15. All but the first were pre-registered at OSF. And all of our participants were randomized to one of three conditions. In all cases, we described a well-intentioned agent who either decided to implement policy A or to implement policy B, or he thinks of A and B and decides to randomize end users to A and B. Our dependent variable was a 1 to 5 Likert scale. How appropriate is the agent's decision? And then we also asked our respondents to tell us something about why. So we had a free response, and we are qualitatively coding those. So far, we have just under 5,900 unique participants, about 100 per condition. So study one was inspired by the Pronovost, non-RCT, but the Pronovost, famous Pronovost study, and also Atul Gawande. So checklist, we have ICU catheter infections. They're a problem, they kill people. We also know there are best practices, CDC approved best practices. And so we give a vignette where we describe a hospital director who thinks that in order to reduce these infections, he will print these best practices on the back of provider ID badges. That's the badge, the A condition. Or in the B condition, he will take the best practices and he will make posters of them and hang them in the procedure rooms. Or in the A/B condition, he will randomize patients to be seen by providers who meet either of those two same conditions. On the y-axis, what I'm going to show you are the percentage of respondents who rated the agent's decision, the hospital director's decision, is either somewhat or very inappropriate. So 1 or 2 on the 5-point scale, because we're really interested in objections to this. Okay, so very relatively few objections to the badge, even fewer to the poster, a lot of objections to randomizing people to both. Okay. Study 2, we decided to replicate this. Let's see if it's really a thing. That's the original. And I should say this is on Amazon Mechanical Turk. I'm going to talk about 3 different samples of respondents. Most of them are on Amazon Mechanical Turk. There's the original result. Here is the replication, also on Amazon Mechanical Turk. The original study, we had a Cohen's d of 1.08, which is pretty good for social science results. Means very good. I mean, it's large, not good or bad, it's large. Regression to the mean is a thing. So in the replication, a little bit smaller, but still quite a sizable effect. We then replicated on a different platform, a mobile platform called Polefish. Again, the effect size went down, but still, I mean, highly significant and a moderate effect size. Study 3, which I don't have time to talk about, we wanted to see, is this just about healthcare and the fiduciary relationship, or is this really a sort of moral reasoning bias that extends to all kinds of random evaluations? So we looked at many other domains, and we found essentially the same pattern, although in some cases, the effect sizes were smaller, so autonomous vehicle design, employee retirement nudges, lots of other things. So why might this be happening? A few plausible hypotheses. You could say, well, education, right? So if you have more education, then you get this and you don't object. Or it could be science literacy as distinct from education, or it could be other demographic variables. No, we collected all of this. We gave them NSF scales of science literacy. We also asked whether they had STEM degrees. None of that, none of it predicted any of the variance at all. So what else could be going on? One thing that could be going on is that when you present somebody with an untested policy option like a badge or a poster, you're just giving them one option, and they are, reasonably failing to imagine the alternatives. Why would we think about alternatives? So sure, badge sounds good to me. Why not? In the AB condition, respondents for the first time see badge and poster together. And so for the first time, they have the opportunity to jointly evaluate those two interventions. And it could be that they have intuitions about which one would be more effective. Now, that itself could be a mechanism of this AB effect, because as we've seen from Pearson and any number of other things, our intuitions are not strong guidance to what does and doesn't work. But that said, maybe this is what's going on. Similarly, but distinctly, it could be that people just object per se to unequal treatment. And so indeed, when we qualitatively coded some of these experiments, we have not coded all of them. It is a laborious and thankless task. We do see that 14% of our respondents either say A or B is better than the other, clearly you guys are crazy, or people are getting two different things and I don't like that. Okay. About 4% of people specifically mention randomization. They don't like that a treatment decision or a healthcare delivery decision is being made by a coin flip. So we wanted to see what would happen if we drained our vignettes of those things. So in study 5, we described a walk-in clinic. In this clinic, some doctors, and we described 2 FDA-approved blood pressure medications, drug A and drug B. We described them only as such, drug A and drug B. Both are FDA approved. We said both were affordable, and both had side effects that patients could tolerate. And we said in this clinic, some physicians prescribe drug A for their patients. Other physicians prescribe drug B for their patients. And it is random which drug you get, because which drug you get depends on which doctor you see, and that depends on an accident of timing and when you show up to a clinic. And so we said in this vignette, Dr. Jones either decides to join Team A and give all of his patients drug A, or he decides to join Team B, or he decides to randomize his patients to A and B. And I forgot to mention this in the checklist, this is a condition in all of our AB conditions, we say that after a year, the agent will look at which outcome is better, and then will offer that outcome. In the case of the hospital director, he will implement whatever poster or badge. In this case, we weren't going to impose a superior drug on everyone, but Dr. Jones would offer the winning blood pressure drug to all of his patients with that new knowledge at hand. So drug A and drug B, happily, those are almost equal, as you would expect. The AB test. Okay. And we also replicated that on Pullfish. Smaller effect size, massive order effect. Don't use Pullfish. So I personally think that it matters what end users of a health system think about learning health activities, so patients, for example, in part because resistance or actual objections or perceived objections by patients can affect policymaker behavior. But it's still important to see, well, patients aren't in charge directly of whether whether a health system implements a policy untested for everybody or does a pragmatic trial. So it would be important to see whether healthcare providers themselves also share some of these opinions. So we sampled healthcare providers in a large integrated health system that identifies as a learning health system. And we gave them both checklist and best drug. And we found the exact same thing. The effect sizes are just as large, if not larger, in this case. Okay, so what else could be going on to explain this? Well, one obvious thing is consent. In our vignettes, we're silent about consent. We don't say there will be, we don't say there won't be, we just are silent about it, but it's totally plausible that people would read these vignettes and think, well, it doesn't seem like this agent is planning on getting consent. And in fact, we do see that 18% of our participants in the AB conditions complain, quote unquote, complain about the apparent absence of consent. This is a little bit puzzling though, because if you look at the policy conditions, which again contain the same untested interventions and hence the same risks as the AB tests, you only see 0.3%, like one guy complained about consent in the policy condition. And it's that, so I'm okay if you think that all of these decisions should be made with shared decision making, I'm totally okay. Where I think that there is a logical inconsistency is if we think untested policy implementation for 100% of people is totally cool without consent, but if you randomize people to learn, then we're in a whole different regime. And that gets back to this whole research practice distinction. What else could be going on? Well, experiment aversion, and it could even be the language of experiment itself. We know from other empirical work, when you describe the same activity as an experiment as opposed to merely research, or even better, a study, just all warm and fuzzy, people actually rate the riskiness of those things differently, even when it's the same protocol. In fact, we find 24% of participants in our AB conditions think that you're experimenting, on people. And so we see language like guinea pigs, playing with lives, flipping dice, rolling dice, gambling, etc. Again, though, I think there's a puzzle here because, again, one guy, like only 1.1% in the policy conditions, which after all are experiments, they're just uncontrolled experiments. They impose the same risks on everybody collectively in the A and the B conditions that the AB tests do. The final possibility is or the final finding that we see is what we're calling sort of an illusion of knowledge. People tend to think that medicine and healthcare delivery are more evidence-based than they currently are. And there are obvious psychological reasons why we all want to believe that. In the best drug scenario, 21% of our participants who approve of the policy explain their decision by saying something like, if Dr. Jones wants A, he must know something. I mean, he must be doing the right thing, notwithstanding that we told them that half of his colleagues are doing B, right? There's this variation in medical practice, but I don't know, Dr. Jones he must know what's going on and what the best thing is. 19% of those who object to the AB test in the best drug condition use the same reasoning to object to the AB test. Dr. Jones should just give his patients whatever works best. There's this magic, he must have magic knowledge. Without studying this, he must know which one's best and he should give it to them. So what have we concluded so far? This is an ongoing research program, and I forgot to mention this is joint work with my colleagues at Geisinger and with Microsoft Research. So we can observe the AB effect in several domains. Educational attainment, science literacy, demographics don't predict any of the variants. After controlling for several of the things that people complained about in earlier experiments, like inequality and randomization, several remaining explanations, consent, experiment aversion, illusion of knowledge, do appear to contribute to the effect, but none dominates. It's sort of a combination of lots of different objections. And this AB effect, as we're calling it, may reflect a heuristic about the ethics of experiments as being inherently risky, as involving bad motives, et cetera, that sometimes leads us astray and leads us to empower people to implement untested policies for everybody. And of course, more research is needed. We need to know more about the causal mechanisms, about the boundary conditions of the AB effect, and also how might we debias some of this. Thank you.
Yeah,
Can I
we'll
jump in?
just
Or-
want to thank the presentations. Those were all thought-provoking. I think it's a great place to start our symposium for today. There are microphones that are or will be available in the audience, so if you have a question, you can raise your hand and we'll bring one to you. But I think it's really just open the floor to Dr. Lee for the first question and or comment in response to our panel.
Okay, so I actually have a confession to make to you. So I run quality improvement for pediatric diabetes, and we're capturing metrics, but we're actually trying to increase engagement sort of at the clinic population level. So one of the things that we've been doing is the hospital had started a MailChimp that sort of gives information to families about events and all sorts of other things, right? Stuff that's happening inside the clinic. And we've been able to sort of take the information in that email and link it up to so we know internally who are those families or who are those patients, right? And so we've been doing some experimentation in terms of trying to increase engagement with it, right? So we created sort of a quality improvement project that was focused on doing factorial design, with which we actually basically randomize people to getting a commitment form versus not in clinic, and then getting a second email 2 weeks, because it's a monthly newsletter, so a subset got. And so it was basically no intervention, A, B, or A and B. But we actually haven't, so we kind of created an IRB that said, we're going to be doing experimentation to learn how to increase engagement inside our clinic, right? But we didn't phrase it as randomization purposely, right? And we're doing this under the auspices of QI, and we're certainly not like depriving anyone of anything that they don't have access to, right? We're sort of like standard of care plus extras. So I've been reticent to sort of describe this or make it public, because we have a website, we have a newsletter. Should we be talking about the experiment, or would it be completely disheartening and alienating to families? And second, what's the solution to this? Because if there's this bias, right, then how do we communicate this in a way? Because I think there's people in this room who believe that the random variation is not beneficial to the public, right? Yet at the same time, we have an obligation to say something.
Yeah, it's a great question. Ask me in another year, I guess, when we're at phase 3 of this project. We have a series of further experiments that we'll be doing to test some of these other hypotheses. What if we drain the language of experimentation, which can be scary to people, alas? What if we drain that from the AB conditions and we add that to the policy conditions? Dr. Jones decides to, Dr. Jones thinks that putting a poster on the wall might work. He has no idea whether it'll work or not. He decides to do an experiment by putting posters on all the walls. So describe a non-randomized, non-controlled experiment as an experiment, see whether that, basically try to make this effect go away, try to make those bars look more like each other. But I don't have the solution right now, and it's bad, right? When there's this gap between, what we're doing. I mean, one problem is people not doing randomized evaluations, either because they don't see the value themselves or because they're worried that, right? But another is doing it, but not feeling like you can be completely transparent about it. And I think, it is literally a research program, or should be, to figure out, and the same is true of data analysis too, right? I mean, lots of people are like, why are you looking at my data? That's creepy. You really literally need to empirically study the best way to describe a learning health system, why it's important, and what are the patient-facing materials that we can produce that in an accessible, concise way communicates the value. But I do think it's not just about describing the nature of the activities, it's also about reshaping people's baseline understanding of what they're walking into in a way that doesn't completely freak them out. Guess what? Medicine's not that evidence-based, right? I mean, that's also scary. So that was a long-winded way of saying I don't know. Sorry.
Are there any other comments to Dr. Lee's question on the panel? If not, we can move to the audience.
So, Michelle, I have a question about this, really a follow-up to that. In our earlier data, when we were looking at similar kinds of issues, we found surprisingly, although we saw some of the same patterns you're seeing, we saw that when patients were being asked, or the public was being asked about randomization, but also about studying things in an observational way, we didn't use that language because in our cognitive memory use that was misleading. They actually found that even if study was observational, they had the same views about risk and concerns and all the ethical concerns. So it didn't look like it was the randomization. It was just like the fact that they were being studied. So I was wondering if instead of just doing it by introducing it into the policy setting, since at least some of your scenarios involve practice variation, introducing it, which is sort of what we did, especially the blood pressure medication, just introducing this sort of study of the practice variation and see whether or not you get the same outcomes that you do when you do A/B randomization.
Yeah, that's a good thought. I mean, that would be another way of certainly controlling for the randomization aversion. Would be just observation. And it is on my research agenda just to figure out people's views of just pure, we're tracking you in the EHR, because we totally are. We are tracking you. And so that would serve two goals, actually. So yeah, I think our colleagues in Microsoft are more interested in the A/B testing, and the genesis of this is actually the Facebook mood contagion experiment. So sort of just long story, but began specifically focused on A/B testing and perceptions of that. But yeah, I think we will expand.
This is more of a general question about the whole learning health systems versus evidence-based practice. The science of evidence-based practice has a certain framework which overlaps a lot with the learning health systems as I'm thinking about that. I come from the field of nursing, so for example, the work of Dr. Melnick and Dr. Feinholt. Can somebody help describe the difference between evidence-based practice learning and learning health systems learning?
I'm willing to have a stab at that if anyone wants to have a better go. I think the LHS is an evolution of evidence-based practice, in that the problem with evidence-based practice is very slow in its learning cycle, its translation of research findings into guidelines into practice, and leaves all sorts of gaps and things in it. So the LHS is an attempt to use electronic health records and systems as an approach to improve both the scale and the speed of that translation and learning process. So it's an evolution.
So I think I have a question that is kind of the intersection of Brendan's and Michelle's talk, which is there any sense that this is, sorry, was that me? Is there any sense that this is based on differences in national populations? You mentioned, having an opt-out, basically learning health system, and I'm curious as to whether that's a response to this sort of concern that people are concerned about being monitored or experimented on or whatever, and so we don't want to mention it to them because it would be lovely if they didn't think about that too hard, or if there's an idea that the UK is different or the NHS is different, and maybe part of what's driving the concern here is the fact that our health system is a giant kludge of lots of profit-seeking actors.
I'll pick the UK bit first. You do have to be quite careful in that there's a societal concordat about what is appropriate for the national health system to do with its data. And by and large, people are mostly happy with the idea that they are given the opportunity to opt out, and that the things that the system does will be either part of routine care or will be focused very much on the benefit and care of future patients. And that seems to be practical. There was a problem a few years ago with something called care.data, when some ministerial representatives were rather loose with the language and gave the impression that data from patients' care was going to be used to inform all sorts of other activities, from insurance to pharmaceutical companies, and might even be sold, and would be perhaps treated in a way that wasn't secure, and that caused absolute uproar. It was a combination, I think, of partly some loose talk by someone who should have known better, and a patient privacy advocacy group who grabbed the weekend news slots when everyone else was asleep or mowing the lawn or something, and set the agenda. And I think it's made people very cautious and careful, but there's a lot more linkage and things going on now. And I think GDPR has been quite good because it's made it very clear and transparent. There are public notices on practice websites, on provider websites. These are the people who are accessing your data, for what purpose, and these are the means and the authorization for which that's happening. So, and people can not just have to request that information, it's publicly available and it's a lot clearer. So I think that helps.
I mean, none of my data speak to this, totally reasonable and interesting question, because it's all limited to U.S. residents for our respondents. I was going to mention the care.data data thing as well. Yeah, so I mean, I'd be a little surprised if there were huge national cultural differences, but it may be that UK practices are, as they often are ahead of the US in terms of communicating some of this better.
I have a question for Dr. Myers. If people are fine with A and they're fine with B, but not with randomization, have you ever thought about, do you think they would be okay with like a time series type intervention where everybody gets A for a period of time, then everybody gets B, so they're in a group and there's no kind of difference between them? And would that work at all, either with QI or in an experiment?
Yeah, it's a great question. We have like an internal Google Doc of about 30,000 billion different scenarios that we want to test, that we're excited to test, including, ABC conditions, things where there's a placebo, things where there's, a control and like a non-active, placebo condition, things where it's time series, all kinds of different scenarios to see. I don't know. I suspect we would still see some effect. Would it be a smaller effect size? Maybe. But I think there is still this is research, and research is scary, that would attach to even that scenario. But you're right, the effect size might go down in that case.
Is there a question over here? Oh, awesome.
Yeah, it's probably maybe too early to measure this, but I noticed in the past year there's been a lot more news about privacy violations by companies and areas like that, and more somewhat getting into health data. And the question is that affecting attitudes and responses to these questions, even though what you're doing at your institution hasn't changed, it probably has even gotten better. There's a story, I mean, the biggest stock price drop in the history of for a company, in the history of any company, only $100 billion plus price, was Facebook when they figured out their privacy policies were a total joke, and the stuff they're doing is a joke, and they're sending fake doctors to hospitals to try to take people's health data. And there's all kinds of other stories on the news about companies buying things buying other companies that have people's data in it, and I think that's getting more into the public consciousness in a way it wasn't even a year ago. And how does that affect what you're doing?
I think it's hard to answer because it is very early days. I mean, I can give you an anecdote. I know it's not really the thing. I'm in my practice. I'm what's called the Caldecott Guardian, which means I'm the guardian of the data in the practice. I'm also the complaints lead. So anything that impinges, and there are always a couple of people who have a real bee in their bonnet about this issue. So I've been through a process with a patient about who has access to my data. I disagree with a couple of things in it, some clinical facts. I think they're wrong. Will you change them? No, they're facts that were recorded at the time. It's now gone all the way to the Information Commissioner, and I've had to respond to the Information Commissioner's office about a number of responses. So I think there are certainly some individuals who are very worked up by the whole idea about things, but I think generally people have much more trust in the health system than they do in Google and Facebook and people like that. Although there was another incident where, and I think this is worth mentioning actually because it's quite pertinent, Google DeepMind, working with the Royal Free Hospital, they received a whole lot of patient information with a view to developing an algorithm to detect acute kidney injury in patients and to build this into something. And I read this, what was happening, because the person at DeepMind is a former colleague at Imperial. I actually emailed him and said, you've got to be very careful about this. This is potentially really a problem. And he rather glibly emailed back, said, no, it's fine, we're just processing the data, just like any other processor of data to the NHS. And I said, you're not any other processor of data to the NHS, you're Google. And that makes a big difference. And of course, it all blew up in their face enormously as a result of that. So people do have to be careful.
Other comments? Okay, next question. Oh.
So thanks to all of you for terrific presentations. comparing Ramesh's work with Brendan's, and I'll focus on those two, there's an issue of scale. Ramesh is very focused on solving a problem for and improving relative to that problem for a specific organization. And Brendan's work obviously is scaled at a much higher level, and I think both are very appropriate LHS activities. When you're trying to solve a problem, is the most appropriate thing to do as you swing through the learning cycle and get to the top and you move to implementation, to do for everyone what you think is the best thing to do, and in a very pragmatic way, but using pragmatic in a different sense from pragmatic trials, see how well that works out. And then if it hasn't worked out as well as you expect, try to fix it, and then cycle through again. I guess to put this to a specific question, Ramesh, did you consider doing an A versus B or implementing two different approaches to reducing no-shows, or did you kind of use the scenario that I just described?
We are doing it sequentially because we have the luxury of 13 different clinics at our school. And so we're implementing different ideas in different clinics. There are some challenges because those clinics are fundamentally different. We are trying to, because in this field, for this to be scaled up to a broader project across other institutions and things like that, there needs to be evidence. It can't just be on what we say. And so we are structuring it like a study and implementing it sequentially, making sure that there is an improvement, and then rolling it out to more and more clinics.
Next question over there in the teal.
Thanks for your presentations. And this again is somewhat directed to Dr. Ramesh. As you guys presented, it just got me thinking when you said, about the larger data set with how people are stratified and not coming in for their appointments based on where the location, and how we draw decisions based on the data. When at times we might be pushed to use this data, like to increase revenue or to balance a budget, but also when we think about research, I'm just learning about the health system, the learning health systems. When we think about research, we have the IRB that kind of, puts these things in place, to safeguard data or to safeguard interests of the public. And when we think about the ethical and legal and social implications, like, who decides and how, like, what are the processes in place to maybe not use this or use it, in the appropriate manner. Sorry if that's a little.
The answer for dentistry is going to be a little bit different because we're largely a self-governed organization. The boards of registration, it's all our colleagues. So, I think that, and I could speak for an hour on my frustration here because the thing is, the incentives are all wrong in dentistry. The incentives are there for intervention and treatment. What incentives are there for prevention and observation? There's little. And the scenario that I painted, that we could to maximize revenue, we could look by race or insurance and make quite a nice sum of money by limiting certain groups of people. But if we think more broadly, why are those people in those categories? And the truth is, at least in our profession, I think in healthcare generally, we don't do anywhere near enough in addressing the social determinants of health. If you look at our health questionnaire, we don't really ask any questions related to social determinants of health. And so it would be superficial to blame them and then go on about our business avoiding treating that group, because actually the reason that they're in that group is extremely complex, and we're not getting the information and thinking through those problems. Sorry, I really could go on for an hour, because the thing about dentistry is, we're in this awkward position in healthcare where is it a business or is it a healthcare service? And I don't like that. I wish we would move closer to being part of the health profession, because there's more and more studies coming out that oral disease affects surgical outcomes and cost of care and reinfection in seemingly unrelated, because surprisingly, the mouth is part of the body. And so it is a great frustration that we decades ago successfully stayed out of Medicare. I say successfully because, well, I think that's perhaps what the governing body wanted, and so now a lot of decision making is to protect the member rather than the patient, right?
Next question.
Thank you for your talks. My question relates to how we define experiments and research vis-a-vis informed consent regulations specific to quality improvement initiatives. And many of the LHS projects, including the ones presented today, can be construed as quality improvement more so than human subjects research individually. And my question for you is how, from a conceptual standpoint from Professor Meyer's work, as well as from more of a pragmatic and practical standpoint, do we draw that line, both with regard to when IRBs need to necessarily be involved, and also how things are pitched to either funders or potential subjects?
Well, I'll make a brief start. I mean, the IRB, the Ethics Committee, has to be involved because it involves patient data. So there has to be an approval process for doing that. I think that actually it is a continuum between quality improvement and what we'll consider to be sort of pure clinical interventional research. And the approval process needs to be flexible and needs to adapt to that. So at the quality improvement end, it should be fairly light touch. At the things where you're doing potentially giving people potentially harmful drugs, doing potentially harmful procedures, if the consequence is unknown, it needs to be very heavy touch. And I think, certainly from what I'm aware of most jurisdictions, that approach is very much the standard now of care. So we really simply, I think the LHS will boost up more the quality improvement end. I'm not sure that's necessarily a great thing for the LHS getting funding and for academic recognition and things, but that's life.
And likewise, even though our project is not deeply, directly affecting patients, we're also one of the first steps was to gain IRB approval. Yeah.
I guess I'm very skeptical about the conceptual distinction that is supposed to be made between quality improvement and human subjects research. I'm still waiting for OHRP to explain in a compelling way what that distinction is. I chair the IRB leadership team at Geisinger. Every time someone submits something as QI, we have to have a meeting and we just wring our hands like, oh, is this QI, is this research? Who really knows? I don't, you need some oversight, not only because of US HIPAA, but you need some ethics oversight, right? Like, so you can A/B test to optimize for the health system's good as opposed to for patients' good, right? I mean, you can use any of these methods to benefit different stakeholders. So, ethics, oversight, I think, is important no matter what we're talking about. I don't buy the QI, human subjects research distinction at all at a conceptual, moral level.
We have a question. One more question, maybe?
Sure.
About 7 minutes. Well, we could do two. It's about
Okay,
6
let's do
minutes.
two. I'll do a quick one then. So my question, mostly for you, Dr. Meyer, I think, is that there's been some interesting LHS research that indicates that if we ask people, people have strong opinions, but if we ask them if they want to be asked, they're like, eh. And so do you guys have sort of that null question of, do you want to be asked, so we know that you care if we ask you, but do you care to be asked in the first place?
I think I followed that. No. I think I know what you're talking about. I mean, there's a lot of strands, right? I mean, there's some research that says, I want to know if you're doing something with my data. I'm going to say yes, you can do it, but I want to be asked. And if you say, well, what if we just told you instead of like asking technically? And a lot of them are like, yeah, that's fine too. So yeah, there's that thread. And so our project so far is not looking at, would consent be okay? Would notice be okay? I mean, those are really important questions. Other people, including people in the room, have done that. Those are things that are important to study. Our project doesn't really get to that. We do in the code book have separate codes for consent and notice. I do think it's important ultimately to do incentive compatible work, because one thing that we also know is that people say, oh, I care very much about my privacy. And like, well, what if you gave me your social security number for like 75% off a packet of like Bic razors? Oh, sure, here you go, right? So, I mean, we know that there's a major gap often between stated and revealed preferences. So we definitely, before we draw any conclusions, about policy and people's actual preferences, we certainly want to study them in that rigorous way.
Last question. Yeah, was there one over here?
So our department, as a department in physical medicine and rehabilitation, is making this transformation now. And we've been in the weeds of like, how do we get teams to even know who they are and so forth. So we haven't thought that much about this, but I do a lot of research. And one of my questions is, has anyone asked, what if we didn't use your information and we didn't innovate our practice? What would you think? I mean, we always think about, consenting them, but what if we ask them, yeah, we're not going to use it. We're just going to guess.
Exactly. I mean, one of my biggest pet peeves is like,
right, that's the option.
No,
I mean, what's the option if you don't use
that's
it?
exactly right. I mean, don't survey people and just ask about one half. Like, you have to make the trade-off salient, right? It's not, because if you just offer someone an option, who's going to say no to an option? Options are lovely. They're great. Everyone wants options, right? Unless you get to like 50 types of jam and then the tragedy of choice or whatever. But yeah, no, you have to make it salient what the trade-off is, right? So we have to use discrete choice methods. We have to use methods that bring that out, that surface that tension and those trade-offs. And that's the empirical data that I'm going to believe about people's actual preferences.
Yeah, I'm just curious if anyone has, literally studied that. What if we didn't use any patient information and we just sort of did our best guess? Because that is the cost of not using it. You benefit from other people's sacrifice.
Yes, you're going to have to teach them what happens. Like the ... and then what would happen is we all know what would happen or what has happened,
right.
but you're going to have to find some way of providing the history books are littered with good intentions and intuitions that didn't turn out to be the case, especially when they were subject to randomized evaluation. But there needs to be like a sales pitch. There needs to be like a PowerPoint deck, right? That have very concrete things that show people, no, really, people really don't magically know. Just because you are elevated to the level of, an attending or a hospital director, or whatever, doesn't mean that you have magic knowledge about what works and what doesn't. It's just not the way the world works. And people don't rock that, I think.
Can I chip in on there? About 4 or 5 years ago, after the care.data debacle, the NHS Research Authority conducted some public consultations around access to data. And I was invited to the one in London as a kind of sort of academic involved in using data in the thing, and told to speak only when spoken to in a factual thing so as not to skew things. But it was really fascinating to watch, because the initial reaction was, yes, you can use my data for research. That's great. Yeah, really good. I like to contribute. It's like I give money to charity and things, but don't give it to the pharmaceutical industry. Okay. And then there were these roundtable discussions where they were given information about what was their health record data like, where was it kept, how was it guarded, who had access to it for routine care, how was it transferred. And there was this crystallizing point where someone said, you mean when I phone the practice and speak to the receptionist, she has my medical record data in front of her? That's outrageous. And for clearly business purposes, they need to see who the provider was they've seen and what medication they want repeated. And this sent a ripple around the group. And by the end of it, the percentage of people who were quite happy to have their data accessed had dropped by about 20 points. So I think you've got to be very careful how you unpack the box. And if you raise people's fears without reassuring them and packing that up, you can do a lot more harm than good. So it's a very, very difficult area.
Before we go to break, is there any other comments the panelists want to make about the promise of this system? If not, that's okay. Okay, well, we just want to thank all of you for joining us for this session. And if everyone could come back about 10:45 so we can move on to our next session. Thank you.
Thanks, everyone.
Thank you.